When African leaders attend spaces like the World Economic Forum, these gatherings are framed as cooperative platforms for solving shared global problems. But global health is not neutral. It is shaped by power, funding, and hierarchy. When individuals with vast private wealth, such as Bill Gates, are consistently positioned as central authorities in African health policy, a deeper structural question emerges. How did private capital come to hold so much influence over public life and death decisions on an entire continent? This question is not ideological. It is institutional. Bill Gates is not a medical doctor. He is not a public health official. He does not operate under African constitutional authority. Yet, through large philanthropic institutions, his funding influences global vaccine research priorities, disease surveillance frameworks, public-private health partnerships across Africa. This influence did not arise accidentally. Beginning in the 1980s and 1990s, many African states were pushed into structural adjustment programs that reduced public spending on healthcare, education, and infrastructure in exchange for debt relief. As governments were weakened, gaps emerged. Private foundations filled those gaps. Over time, financing quietly replaced sovereignty. Large-scale philanthropy does not function like charity at the local level. It functions like an operating system. Funding arrives with predefined metrics, performance benchmarks, reporting obligations aligned with donor priorities. This means African health ministries often shape programs not around local epidemiological realities, but around what funding is available. The public rarely votes on these frameworks. Parliaments rarely debate them, yet they govern millions of lives. This is not corruption in the traditional sense. It is structural dependency. African skepticism toward global medical campaigns did not appear randomly. Across the 20th century, African populations experienced pharmaceutical trials without informed consent, medical testing during colonial rule, post-independence programs with no long-term follow-up. These practices are documented by medical journals, historians, and human rights organizations. When communities remember being treated as testing populations rather than protected patients, trust erodes. This is not rejection of medicine. It is historical memory responding to unequal risk. Health emergencies compress decision-making. During crises, debate is framed as dangerous. Dissent is labeled irresponsible. Funding is offered with deadlines. When African governments engage global health financiers during emerging outbreaks, scrutiny is reasonable. Not because medicine is evil, but because urgency removes meaningful consent. Decisions made quickly often shape decades of outcome. Real health sovereignty requires African-led research, regional pharmaceutical manufacturing independent regulators. Public accountability aid without autonomy is not partnership. Africa does not need unelected health guardians. It needs control over its own survival.